The clinical trial suggested that patients who were biopsied and shown by immunohistochemistry to have staining for PD-L1, which was defined as greater than 5% in the microenvironment based on the DACO antibody used by Bristol Myers Squibb only, that those patients had improvement with anti-PD-L1 antibody alone. And this really highlights just the complexity with PD-L1. So the molecule PD-L1 has been very difficult to develop immunohistochemical assays for. All of the different companies with drugs have different assays that test different things. So it's not at all the case that a patient who's positive over here is necessarily positive over here. And so patients get very confused about this. It's also confusing about how are we going to take this forward because there's no validated across the board assay that everyone is using. It's even more complicated in that PD-L1 is an inducible ligand. It's not always there or not. It gets turned on and off such that it's quite plausible that if you do a tumor biopsy, depending on where you put the needle in the tumor, you may or may not find the PD-L1, which means there may be patients who are positive, we don't find it because we biopsy the wrong part of the tumor. And that's manifest by the fact that up to 10%, maybe even 15% of patients who are negative actually have responses to PD-L1 antibodies. In addition, PD-L1 is really just a part of the description of the immune microenvironment in the tumor. In fact, the model that we're using is something called the T-cell inflamed tumor microenvironment, which suggests that the immune cells are able to get into the tumor, they know it's there, and when they get there, they're just not able to complete the job and kill the cancer. We think in melanoma that's approximately 40% of patients, and that correlates pretty well with PD-L1, but not exactly. And we can test that by doing gene expression profiling, but that's a research test. So how do we then build this in to eventually, become a clinical test? We're still working on that. Clearly PD-L1 is useful, it's not the whole story. And so I think we'll need further iterations of biomarker development to truly predict the benefit from immunotherapies such as anti-PD-1.